the years, MS TeamWorks has shared perspectives on MS from all members of the MS team. And although 2020 brought unexpected challenges, we were determined that a pandemic and social distancing would not stop us from sharing new and meaningful perspectives. The setting was different, but the message is the same. I have MS. I have a team. I have a future.
Hi, my name is Denise Bruin, and I'm an adult nurse practitioner who specializes in treating people living with multiple sclerosis. For the past 10 years, I've worked in a multidisciplinary MS clinic at a large academic center. Oftentimes, patients will tell me that they're not sure what a relapse is, if they've even had a relapse, or what that terminology even means. So, rule of thumb, a relapse is typically a new neurologic issue that lasts longer than 24 hours continuously and that the patient does not have a fever and does not feel sick. So I repeat this to my patients multiple times, especially my newly diagnosed patients, because oftentimes every little twitch, buzz, feeling, whatnot, they're wondering if this means it's their MS and should they call us. So giving them that checklist in their brain to kind of go through can be very helpful. I also tell my patients that I'm never going to fault them for calling me or reaching out to me and saying, this is going on, is this a relapse? But it can be very anxiety provoking if patients don't know what they're looking for or when to access care. So again, typically a new neurologic issue lasts longer than 24 hours continuously and not in the setting of a fever or infection. A pseudo-relapse is not that we think patients are faking a relapse, but it's usually a recrudescence of old symptoms or old symptoms that a patient previously had that are more annoying or that the patient is noticing more when typically those symptoms might be kind of quiet. A very common phenomenon is Uthoff's phenomenon. So this can be somebody had optic neuritis previously and lost vision in one eye. It healed to the best it can. Their vision baseline is pretty much back to normal, but maybe they get overheated or they're sick and they notice that the vision starts to go in that eye again, which can be very scary. That's your vision. Once they cool down or we treat the fever, the infection, their vision comes back. So this can happen. I can think of several patients that like to exercise or do marathons, and they know by so many miles in, once their body temperature is up, their vision's going to get less in that eye. And when it first happens, again, it can be very scary because they think they're having a relapse. But it's really just that their system is kind of overtaxed with everything going on, and we need to cool them down, treat the infection. Fatigue, not getting enough sleep can also cause this phenomenon. Stress is another thing that can cause that. I've even seen it happen to folks after doing like colonoscopy prep where they have to drink and clean out and they notice that they just feel weaker or some of their symptoms are more elevated than they normally would be. So this is probably one of the biggest things that patients call our office about because, again, it can be very scary. And oftentimes patients will report that it feels just like it did when I was first diagnosed. And to me, that's almost reassuring because to me, that usually tells me this is a pseudo-relapse and not a new relapse because, again, it's old symptoms that are becoming more evident. So this is a case when I would direct somebody to get a urine sample done or blood work with their primary care doctor. Oftentimes there is a urinary tract infection and that's causing enough of a low-grade fever or kind of a low-grade irritation to somebody that their symptoms are becoming more obvious. Where I live, it gets very hot and humid in the summer. That's another time that people can really see having a pseudo-relapse. Again, not getting enough sleep or just having increased stress. So again, it's asking the right questions, picking things apart and making sure there's nothing else going on and not just assuming that this is a new area of inflammation in somebody's central nervous system. If somebody's having a relapse, again, this would be new numbness, tingling, weakness, bladder issues, vision loss. This tells me that they're having active inflammation in their central nervous system, that their MS is still attacking their central nervous system. So patients can heal from the damage that's been done, but there will always be some residual left to that area. And over time, accruing all this is what leads to disability. Sometimes it can take years before we see that. Sometimes it can be more cognition that we see versus physical issues, just because of little areas in the brain that keep being attacked or inflamed. So the point of all the medications that we use, the disease-modifying therapies, they don't fix anything that's been damaged previously. The goal is to prevent new areas, new lesions, new relapses, exacerbations, to prevent new things from occurring so that more issues don't occur for the patients, that they don't accrue disability. So I oftentimes, again, go through that checkbox with my patients. Sometimes they've had MS for 20 years and they're still like, what's a relapse again? I don't know if I've had one. And then going through their history, which I keep a record of in their medical chart, when you had optic neuritis, that was a relapse. But sometimes they can be much more subtle. So again, I educate patients when I want to hear from them, how to access our office if they suspect something's going on. And I also don't want them to feel that they shouldn't bother us or if they think something's going on. I mean, we're there for them to reach out to see if this is something concerning. Most relapses with time will heal to the point that they're going to heal on their own. But when something new happens to patients, obviously, they want to get in for care as soon as possible. And we also want to make sure, is this a relapse or is there something else going on? Sometimes relapses can be uncomfortable. So with pain or nerve pain, so we also want to make sure that we're getting the patient in, diagnosing them, getting them in for whatever treatment they might be after that relapse, which seems to be the best course for the best prognosis and recovery from the relapse. So optic neuritis is one of the most common symptoms that brings a patient into our office or into being diagnosed with MS. So this can be painful vision loss in one eye. Other things can cause this. Most commonly can be optic migraines. So sometimes patients will contact me concerned that they are having another case of optic neuritis. And again, losing vision in your eyes can be a very scary thing because that really changes everything about your life. So sometimes based off of what patients are telling me, if they call in and it sounds more like an optic migraine than optic neuritis, I might direct them first just to take some Aleve or an over-the-counter NSAID and see, because that is not going to treat optic neuritis, but that will treat a migraine. So that can also be kind of diagnostic in terms of the patient's response. Sometimes patients carpal tunnel is a huge thing that seems to come up. Patients will come in and say that their hands are numb. So many of us are working on computers nowadays, working with our mouse, or we're on our phone constantly, that carpal tunnel seems to be an ever-growing phenomenon. And sometimes patients will interpret that hand pain or hand numbness as a relapse. So again, it's seeing what is their activities in life, doing the examination, what's their job. Again, asking all those right questions and not assuming that this is just for multiple sclerosis. And what else can be done, again, to make the patient more comfortable and to get the correct care. And again, not assuming that this is all based off their multiple sclerosis diagnosis. For me, with my patients, when they're sorting out what's a relapse, what's not a relapse, again, I think it's my job, my office staff's job to, one, educate my patients as to what those differences are. Also, when to access our office and not to be apologetic about accessing our office if they have a question about what's going on with their central nervous system. It can be very scary, especially when patients are first diagnosed, as to what's going on. People become hypervigilant with every little sensation or feeling. So I want them to have some feeling of control over their body as well. And again, those checklists, and if they meet those checklists or they're still concerned that there's a relapse, feeling that they can reach out and being heard, and that we will do what we feel needs to be done to see what's going on. Do they need steroids, or is this something else that we need to address with them?